Well, Drew, we're kind of talking about CPR during this episode. You've done chest compressions, right?
I have.
Yeah. So I was training this student the other day, and they told me that one of their teachers was talking about CPR, like doing chest compressions. So I just want your feedback. The times you've done chest compressions, have you felt the sternum break, or have you noticed it was broken, like when it came to
Yeah,
your
I
turn?
mean, when I was doing my chest compressions, and even when we were switching out, because I think the last code that I ran or that I was a part of, it was, I believe, 20 minutes. And almost
Mhm.
every time that it was my turn to do chest compressions, I could feel popping in the chest, like the bones either slipping or I could feel either a new break happening. So yeah, I every code that I've been a part of, I've felt somehow the sternum is broken, or I've broken
Right.
it.
So the student was telling, like, I shared that with the student because she had never done chest compressions, and I was kind of like preparing her for that. I'm like, if you do chest compressions, it feels weird when that sternum breaks, and I was like, you need to understand that that's pretty normal. And she told me that that's what she thought, that's what she's been told her whole life. And one of her professors was like, anyone that tells you that you need to break the sternum to do effective chest compressions is full of shit. I was like, "What?" I'm like, I'm training you, and I'm like, that's from my experience. I don't know how you can actually compress. I don't want to like start a fight with this nursing professor, but I don't understand how you can do effective chest compressions without breaking sternum because you need to compress like 2 inches.
Yeah, I
I feel
Yeah,
like to get that,
there's no
agreed.
way. There's absolutely no way that you can do effective compressions without popping the cartilage. Like
and I
maybe
know,
breaking like the hard bone of the sternum, yeah, maybe, but like you break it from the cartilage. It's that cartilage that's popping. There's no way that you can compress the heart appropriately without doing that.
right, and it just like blew my mind because um, especially in an emergent situation, I'm not gonna do compressions and consider like not breaking the ribs. Like ribs do take a long time to heal, and you can have other problems that come from like rib fractures, like a punctured lung and stuff like that. But we can fix that stuff. We It's kind of hard if we wait too long to bring someone back to life. You know what I mean? Like we need to act fast.
Plus, like, if you don't push hard and like deep, the doctor's gonna yell at you, telling you to improve your compressions or switch out. Someone else get in there.
Yeah, yeah.
Oh,
Man,
go on.
I honestly haven't done that many chest compressions. I think I'm either a good luck charm or a black cloud, as they say, because I'm usually in line to do compressions on a lot of these cases. By the time it gets to me, they either say we're calling it or the patient came back. I've only done chest compressions like twice on an actual human being.
How many like codes have you been a part of, Thomas? Because I've seen like a few, but just in like my clinical experiences, where you've been like a CNA since like the beginning of time. How many?
Oh my gosh, looking back, I've almost been a CNA for a decade. How about you, Drew? You've probably been in it a while too, haven't you?
Yeah, I've been a CNA for 6 years.
Yeah, yeah. So I've officially been a CNA for like 9 months, back in October of this year of 2020. But man,
How many codes
oh,
have you seen?
I don't know. I'm trying to think of that. Like I used to work in a nursing home. Like I've done almost every CNA job you could have. Like I worked in a nursing home. I wasn't there very long because the environment was terrible and depressing. Like, please, listeners, don't ever send your parents to a nursing home, okay? At all costs. But I also worked at an assisted living home, which was nice. Like, if you're gonna send your parents anywhere, send them to a assisted living home. At least they can have some dignity. And go visit your family. Sorry, there's my 2 cents right there. Like, go visit your family members that are at a home. It's just mean to like just ditch them. But I also did home health. which honestly was my favorite job. It was kind of hard because you're like on your own at these patients' houses, but I didn't have anyone code doing home health. I had a patient that had seizures frequently, so they had like oxygen on board. I would just monitor like a pulse, and like I was ready in that situation. Like if anything went worse than that, I was ready to do compressions. But luckily, we just put oxygen on and they improved and came out of their seizure. But I've been working at the hospital for 5 years, and I would say on average, probably have seen like 4 to 6 codes a year. I was like, I was usually as a CNA, I was the gopher. Like I would go grab the crash cart, so like the defibrillator and stuff like that. Meds were usually in that cart. CNAs aren't technically supposed to like be alone with the crash cart because drugs could mysteriously walk away, I guess. But um, obviously, I'm in good standing. If anyone in the government is listening, I have never taken drugs out of the crash cart, but I have always like ran and gotten that and brought it to the patient's room where there was a code situation. The nurse would be like, third drawer, I need this. Fourth drawer, I need that. So it's very important, like especially in an emergent situation, that you are organized, that you know where your materials are, and that you have somebody to get stuff.
Thomas, you've been a CNA for 5 years at the
Right.
hospital. You've seen on average 4 to 5 codes a year. So you've probably been a part of like 20 to 25, maybe 30 codes situations. How many of those have you seen like actually be effective where like the patient survives?
Ooh, some of them I felt like the nurse called it because that's where we were headed. Um, I wouldn't say uh, like there's other things that you can call in a hospital setting, like a staff assist kind of thing. Like
Yeah.
that's when things are starting to go downhill. Like we need to get ready and get supplies ready. If I were to count those, it would be the number would have been a lot higher. But
Well,
um,
I feel like TV like plays it up like, oh, shock them and bam, they come back. Wow, this happens all the time. But the few that I have been a part of, every single one of them has not survived. I
mm,
I always expect it to be a lot higher of a success rate.
Yeah.
right.
So,
I
oh, go on, Tom.
So I will say this: what I have seen does not correlate with what we were taught, like on the percentage of effectiveness. Like I said, I think I'm a good luck charm or a black cloud because they usually call it before I do compressions. Like I've only done compressions twice, like I said, but I would say on average about half what I've seen, which that is like a crazy high number.
Yeah.
Well, actually, Tom, I I have a report submitted by the VA in correspondence with the American Heart Association that adults who have received CPR in the hospital, about 56% die during resuscitation. So 50%, that's 44% are surviving CPR, which
In a
is
hospital setting,
in
which
in
that
the
makes
hospital.
yeah.
So there's another metric that about 90% of resuscitation that happens outside the hospital doesn't work.
Yeah.
Yeah.
Um,
I think that's the big thing is getting the AED or defibrillator there as soon as possible.
oh yeah.
Um, I've I took an EMT class once and I did compressions on a patient in that class, like during a shift rotation, and since it was just the two of us, I forgot what the machine was called, but it was just me and this other guy, and you're supposed to switch like every 2 minutes. And it was taking us a while to get to the hospital because people are stupid and need to get out of the way, urgent vehicles. We had like this machine that was doing chest compressions for us.
Oh yeah,
I
that
forgot what
big
it was
like
called.
it's almost like a jackhammer almost, but
Yeah, exactly.
it
Because
it
the
like
rate of doing chest compressions is like 100 to 120. So yeah, it looked like a freaking we were doing construction on this poor old man.
Those things are terrifying.
yeah, they
Yeah, it was a little nerve wracking, but kind of like what we said about ventilators is whatever you are comfortable with, is the best option. Like
Yeah.
best ventilator setting is what you know. And this EMT, like he knew how to do it.
And plus
Granted,
it
this
removes all error. Like there's no, it's going to give the same compression, depth, and power every single time. Not, it eliminates the human error of it.
right, exactly. I was gonna bring up the human error thing, but you nailed it. But that's like people get fatigued. We're only human. That's why you're supposed to switch like every 2 minutes. So, um,
Yeah, and
but most
compressions will kick your butt. Like
oh
it's
yeah,
it's
yeah,
amazing. Like I'm a big dude. I have like a pretty good amount of muscle in me that I can last for a decent while doing compressions, but it it kills you. Like
yeah.
it's rough.
Yeah. It's crazy the amount of cardio you probably should do working in healthcare to prepare you for that. And it's like you see EMTs like they're usually pretty bulky, and it's because of I feel like it's because of chest compressions is a huge part of that. But
It's a
even
good
then, I
workout.
see EMTs get burned out too. Oh yeah, and they work out all the time too.
Yeah.
But I've seen EMTs get burned out too, and it just blows my mind because I'm like, you're like the Incredible Hulk. How are you tired? But yeah, chest compressions kick your butt.
I remember the first time I did chest compressions, and it was like after I don't know 45 seconds to a minute, I was like, "Holy cow! It feels like it's been 5 minutes." Like just in the zone, and then just the exertion that you have to do. Because my first one, I remember he was like a 400 or 500 pound guy, so we were having to push hard, and it was amazing how drained I was after that.
Mm.
Yeah, it's a full body workout, that's for sure. Halfway in, you start
Oh
praying
yeah,
for someone to take over for you.
Well, there's that support that, even if you aren't at the 2 minutes, you can ask someone to swap out with you.
right. And I think you need to be man enough to know where your limit is, because you need to put your pride aside and put the patient's needs before your pride, if that makes sense.
Oh, absolutely.
Yeah.
Well,
It,
but
it also feels better coming from yourself and you're like, hey, I'm tired, rather than the doctor being like, hey, this guy's weak as hell. Get someone else in there.
Yeah. Switch them out. Switch them out. But yeah, it kind of bugs me during clinicals. I feel like students get brushed off to the side in a code situation. And like I was legitimately standing in line to do compressions one time, and the freaking ICU nurse like kicked me out of the room. It was
Really?
like I was not. Yeah, I was like, what the freak? Like she pretty much treated me like I was just taking up space. I'm like, I know what to do in the situation. I'm waiting my turn to do compressions. I don't know. I can't speak for all students. Maybe some students are prefer to be a fly on the wall and don't do much. I can understand
yeah,
previous students maybe being like reserved and stuff like that, but I was ready to go,
you know,
and I thought it was messed up that she didn't want my help.
yeah. Well, that is kind of messed up, but I do understand it because there I've only been in clinical one code situation, or actually two now. Um, but I always hear these stories that sometimes you do just become kind of a fly on the wall because you may not be comfortable in the situation, and other times you are in there helping. But from my understanding, not to knock our nursing students out there in the world, because they do have an important role and they are our future coworkers and a huge part of the medical team. But what I frequently see is these nursing students that are just standing in the room in the way, and I hear about this frequently. The first code I had in the hospital, I I was there. I got called to the head of the bed and I started bagging the patient. And I actually helped. It was great. I'm sorry that you got pushed out of the way, but I think that it might just be that they would rather have like people they know are like competent in it.
They,
Because the second code I experienced. I got out of the room as soon as I could because I knew that I didn't know what was going on. So I was just kind of fly.
That was the one. That one where you just got out of the room. We were at the same facility, weren't we? And they were like gonna do a weren't they?
Oh, I forgot about that code. No, I was I was in a different unit. That's right. This code. For you listeners, this patient had varices in her lungs, which caused some issues during a bronchoscopy and caused her to code. But I I remember me and my preceptor were walking down the hall to help, and Tom, you were just staying outside the room, and me and you were just outside the room watching.
That was the code situation that I got kicked out of.
Yeah, that was that code situation.
I was ticked. I was so livid. I was like, but I'd already seen like a bronch done before that. But like my preceptor was like, get in there, like see the bronch, and I'm like, well, that lady doesn't want me in there, so I'm just gonna stay out here.
Yeah. So I feel like I should explain what varices are. They're kind of like little holes that they're similar to fistulas, but they carry blood instead of just being like an opening. And these were lung varices, so they connected between the lung and I believe the esophagus. And it caused like a huge amount of bleeding. The bronch was very interesting, but yeah, I'm sorry that was the code you got kicked out of the room. I was in the room more than you were because I had to.
I was pretty sure you were there. I thought you were in the room before me.
I completely forgot about that.
I thought that was technically your preceptor's patient, but you guys were busy doing something, so we jumped in.
That's right. It was our patient. we were stuck somewhere else. That's right. I remember now. I've been a part of more code situations than I remember. Whoops.
There you go.
But yeah, no. Yeah, it's unfortunate that you got kicked out of the room there. But at that specific hospital, they have like a specific team they want in the room, and students aren't really a part of that.
Oh, I think most facilities they have a code team that they call.
Oh yeah.
They respond to every like staff assist or like code blue situation. Staff assist, I think I should explain that just a little bit more. That's like that could be anything. Like a patient was found, or even a visitor, like slipped and fell on the ground. They're responsive, but they just want medical to check them out. Which staff assists usually aren't very emergent, especially if it's, I'm going to say usually not, unless it's like an inpatient. Then like a staff assist for an inpatient is like we have an irregular heart rhythm. The heart rate is like super high and we're expecting it to drop to zero kind of thing, or vice versa. The heart rate's really low and we think it's going to keep going until it's going to keep dropping until it stops kind of thing. Um, there are medications that we can give to help with that. My opinion about like CPR stuff, it's better to prepare and prevent than like prepare and prevent than to like repair afterwards, like try and fix it after it happens kind of thing, because there are signs that you can watch for a person coding. Yeah. Um oh, Drew, do you want me to talk more about like code situations that I've seen? Oh, Mm. Mm.
I think with codes, like a lot of it is just like hearing experiences is good just because you don't really know what to expect until you've been in them. But when you've heard how they go, like you get a little bit more of an understanding. When I like my first semester, my first clinicals in like a 2 week period, I saw like 4 or 5 codes in clinicals.
Oh my gosh.
And it was the first time, and it was just like insane. And then like after that, my clinicals ended, and that next weekend I went deer hunting. And while I was out deer hunting, some dude had a heart attack and ended up going to like a code situation where we were like doing chest compressions and like breaths like out in the mountains. And I was like,
Oh my
I would have
gosh.
no way how to handle those kind of situations if I hadn't like been in other code situations. Like you just get more, not better or whatever, but you get more familiar with what next steps you need to take and like just reacting to the situation. But I remember just thinking,
Exactly.
like that one out deer hunting like will be in my mind forever just because it was just like I was the only one that had any bit of like experience in this situation, so they were like asking me what to do, and it was like somebody that I knew, so it was very tough. We were doing like, I remember this was at like 10 or 11 o'clock at night, and me and my little brother were in the back of like a Ford F-350 doing chest compressions on this dude going down a dirt road on the side of a mountain while ambulances were trying to meet us there. It
Oh
was it was
man,
so crazy.
that is a crazy one. I don't have a story that's even comes close to that, Trevor. But definitely, I think exposure is key. If you're just observing, because definitely the first code situation I was a part of, I don't feel like I did much because I was definitely like deer in headlights. Like I had all the training that you should have. But man, it is totally different when you are in that situation.
Yes, it is.
I am definitely more comfortable now. Like obviously I've been in many situations, but the first one, yeah, it definitely catches you off guard. So I think that's a key thing for. They say effective CPR starts with like effective chest compressions, but I think it's exposure. So like you can actually perform in those situations. Because like I said, I was a deer in headlights that first one that I saw. But yeah, like it is totally normal. Like your first one, maybe your first three, but I've definitely seen a lot of stuff in my line of work, like at the hospital and uh, taking EMT classes and stuff like that. But yeah, you need to have that foundation though of training of like what are the compression rates to respirations. Like now that I've kind of progressed from like CNA training, like I taken EMT courses and stuff, like I've said, like I know there's drugs that we can give, and even as an RT student, we've learned that there are drugs we can give, but that's past what basic people know or should do. I think what most people should do is just not be scared of doing CPR if they see a situation, because I think too many. Oh, this relates to a story that one of our professors was talking to me about. He knew I was a CNA, and he was like, "How many people have you seen die that you have taken care of?" And I was like, "Oh, I've seen my fair share." And he's just like, "How do we help students realize that when we like withdraw life support or and people die during a code situation that it's not our fault as a student or as a respiratory therapist?" And I pretty much just came to the conclusion like, what would happen if you didn't intervene? Like it can't get any worse than dying. So anything that you attempt to do, I feel like is for the benefit of that person. I had a preceptor tell me once. He's like, the RT that claims to know everything is a hazard. like you need to understand that we are all improving. Like everybody makes mistakes, and we need to be open to that input to progress. Because that moment that you think you know everything is when you're going to harm a patient. Um, so I would say have that mindset open. I think we kind of already talked about this. Is you need to put your pride to the side and be open for that opportunity to learn and progress, because there's always ways we can progress. Like common practice is always changing, and we need to make sure that we are up to date on that, which kind of goes along with like ACLS and BLS. I think one of our teachers said that they're changing the format a little bit this year. I don't think it changes like crucially, but they definitely like change how soon you give certain medications and how soon you should like give compressions. Like I think the standard right now is you should check a pulse and breathing for like 10 seconds. They want to cut it down to like 5 seconds, which totally makes sense. Like you want to get to it as fast as possible, like performing compressions if you need to.
Oh, sure. And 10 seconds is a lot of time. Like
Oh yeah,
if you count to 10, like it takes a while. You should be able to, be able to feel a pulse and, at least check if they're breathing in that amount of time.
oh yeah, and I remember when I did BLS training. Like I said, I've been a CNA for a decade now, almost. But it was like you need to send someone to go call like EMTs and stuff like that. Hello, we have cell phones that have speakerphone capability. Like you could talk while you're doing compressions. Is it
Absolutely.
ideal? Probably not, but you could.
So I have a friend that's a dispatcher for the San Diego area. And he talks about how, they want people to put them on speakerphone next to them as they're, going through CPR, and they'll help walk people through it.
Oh, totally. Like I think the advancement of technology obviously has helped medicine, but I don't think we've ever thought of the ability to put a phone on speaker um, would make a difference. But I feel like it does, especially like you said, Nick. Like dispatchers can walk you through stuff to do. Like they'll even like suggest things to check. Like um, yeah, like do you know if this patient has like a medical history? Like what kind of medicines do they take and stuff like that? Um, because like information is power, especially like as much information as you can gather and give to the person you're going to hand off care to, like an EMT or hospital staff kind of thing.
Can you guys imagine? You might not want to put this in the podcast. I don't care. I I just had an idea, if they don't already, if like eventually they're gonna have like your a smartphone have the capability to be an AED, where you just like have stickers that go onto your chest or whatever, and then you plug it into like the charger port on your phone, and when you do that, it just like takes over on your phone and makes it an AED.
Oh
And
my,
then we're
okay. Trevor, I'm going to chime in for a second.
yeah, go ahead.
I remember watching medical shows. I swear I want to start an Instagram page if it hasn't already been done, because I'm not the smartest person in the world. Somebody's definitely come up with this idea before me. But I've watched medical shows where they trust an Apple Watch to show the doctor the heart rhythm and the
Oh my
pulse.
gosh.
And it blows. I'm like, hell. I mean, sorry. Definitely not. I would
No,
not go
no,
off.
definitely not.
No way. I would never rely on an Apple Watch. Okay. So I feel like that's kind of my opinion if phones did develop that
Oh,
far.
I'm just saying, like, say you're in a car accident or whatever, and you get into your first aid kit, and you've just got these like straps that connect to your phone, and then you plug them in and hook them on before the ambulance gets there, and you can have a little bit more detailed.
Pass on.
Yeah, it
Yeah,
was
yeah, but
just a thought. I was like, that could happen. That could happen. With the way
I mean,
technology is advancing, it's not out of
it
the
could.
question.
It could. It's
Yeah,
not
I
out of the question by any means. I totally hear you.
I feel like there's a safety issue with that though. It's the thing. Like AEDs are made to, be as
Doc, I
simple for
guess.
people to use, but I feel like having that much portability is a problem with just, safety of using the phone as a phone.
Oh yeah, I totally agree with you, Nick. Like
Yeah, you're
we,
right.
Trevor, we have people today eating Tide Pods. Okay, somebody would attach that to themselves and be like, "What happens if I shock myself?" But I agree with you. I think accessibility um, can be a hindrance. Like we need to make sure that like an AED is close by, like if we can.
Well, in the
Like
hospital
I hear you
setting,
there.
thankfully AEDs are close by, but like one a lot of businesses these days do carry them in their building, which is nice. But I feel like more common businesses need them, like McDonald's, for example, to name drop a very specific business. Other fast
Here's the
food
thing.
restaurants are
I
available.
bet they have them. I bet they have them, but I bet you they're
Behind the counter.
only accessed by the staff.
Yeah.
I should
Um,
I should figure that out. I should contact like fast food restaurants and ask if they have.
Before you accuse anyone,
AED.
maybe do your research, Nick.
No, you are right, but
I'm just
um,
kidding.
the problem is that if they aren't openly available, there's an
that is
issue
really
with
true.
response time.
Yeah.
So, like,
Right.
at the university, on each one of the floors of the health science building, there's an AED next to the elevator.
And
So,
I think it's because
That's
it's a
true.
health science building. I don't think any other building at our school has that many AEDs in
nope,
one building.
there is. The English
I feel like
building
in the student union.
has. Yeah, student union has a bunch all over the place. The English
Yeah.
building has one on each floor.
But
Um,
I don't think I saw more than two at the library.
really.
I I will say though, I was impressed. I took my son to school the other day, and I saw I think 3 AEDs throughout the entire elementary school. I was surprised to even see really one, to be honest. But it was cool to see that I don't know. I feel like 20 years ago, granted, I wasn't looking for these, but I had no idea what an AED was. I didn't even know that they had portable things like this, and it's just cool to see that nowadays, like all over the place, that people are more aware of how to basically the very basics of saving a life. At least they should.
Yeah, I think everybody should be CPR certified. I think even most places of employment require it,
Yeah.
or at least they have a training like for new employees on how to do CPR. I don't know if everybody is officially certified and has a BLS certificate, but at least they have like that basic training, if that makes sense.
Oh, I absolutely agree. I feel like you know, it's one of those skills in life. Like knowing how to do your taxes is just nice, but knowing how to save a life through chest compressions or how to help someone who's choking, I feel like that needs to be just kind of standardized. I think that, health classes in public education should probably teach that.
I would agree with that one. I think you couldn't. It couldn't hurt anyone to actually know more about how to save someone's life because you never know. That's why they call it an emergency. Like you're not planning on this, but it happened. You know.
Oh, absolutely.
Right.
So I think now is a great time, great great segue into presenting to you listeners just the basics of life support or BLS. So who any volunteers for just picking up the algorithm?
I can start it
Sure.
off.
Go ahead, Trevor.
Yeah. So first thing you do when you get to any sort of situation, you want to verify the scene is safe. No need in putting yourself at harm. If you end up getting injured, you're not going to be able to help someone else. So
Sorry,
make
Trevor.
sure that the
Can I throw something in real quick?
yeah, go ahead.
It was drilled into me with every EMT that I followed. They said rule number one: about taking like emergency situations is don't become patient number 2. Rule number 1, don't become patient number 2. So that's the keyest point of assessing a scene being safe.
Well, it's a key point with any emergency. You don't want to become another victim. You don't want to be the next patient.
Right, because that just uses up your resources, and especially like EMTs, they're trained that you take care of your partner first, and you just robbed that patient of care that they could have been getting.
Mm-hmm.
Sorry to cut you off, Trevor.
No, you're good. Thanks. So once you do verify that that scene is safe and you are not going to become patient number 2, then you can start doing some assessment here. Um, you want to verify that they are unresponsive. Give them like a good sternal rub. See if you can't wake them up. Um, and then shout for help. Get some help on its way immediately, so that you're not all alone doing this by yourself. That includes, which would be the next step, is activate the emergency response team. Have someone call 911 and get an ambulance on the way. The faster they get there, the faster they can get the patient to the hospital, and drastically increases the survival rate. And then get an AED as soon as possible, as we've kind of already talked about. Very important. The AED is going to be one of your best friends. It helps to maintain a proper CPR rate. It kind of walks you through everything else of what you need to do until paramedics or a trained professional arrives on scene. So as soon as you can get that AED on, do it, because then your job becomes so much easier.
Okay, so after you of course do this first little bit of getting things moving, you need to of course check to make sure that or check to see what kind of emergency is. If you need to look see if they're breathing, or if they're not breathing or if they're gasping, and check the pulse at the same time. Uh, it's a simple maneuver. Just position your ear over their mouth and nose, and then watch their chest while feeling their carotid artery for a pulse. You can do all 3 of these things at the same time. You listen for breaths, you look for chest rise, you feel for a pulse. So it's one swift motion, and as we talked earlier, 10 seconds at the max. So, if
That doesn't mean take the full 10 seconds, okay?
sure,
If you
if
can do it faster, do it.
absolutely. So, but if say they're just unresponsive, but they have normal breathing and they have a pulse, you just stay with them until paramedics arrive. If they do not have uh, any breathing, or their breathing isn't normal, and they have a pulse, you then need to just switch to providing rescue breaths. Which to do that, you do a breath every 6 seconds or so for as long as you can, for maybe 10, 12 minutes. Of course, you want to make sure that an ambulance is on the way, and you want to check a pulse every 2 minutes while doing this. If they switch to not having a pulse, you need to continue on to the CPR algorithm, which you would have initiated if they didn't have a pulse when you checked in the first place. So,
Right, Nick, can I
CPR.
pause you there?
Yep, go ahead.
Before we go to CPR, I want to go to a situation that I was a part of where the patient was breathing fairly normal, had a pulse. I was actually at church, and this guy just collapsed and had a seizure. I think another part of making sure the scene is safe is making sure your patient isn't gonna like harm themselves. So we had to like make sure we cleared out chairs and stuff like that, and just tried to stabilize his head. And yeah, we just waited for EMTs to come up, but we never had to do CPR on him because he had a pulse and was breathing effectively enough. So
Absolutely
there are
not.
situations. I feel like we always focus on the worst case scenario, so I just wanted to throw in a situation where a patient has basically normal breathing and a pulse.
Oh, sure. I mean, I believe a majority of emergent situations aren't cardiac related. Oh, they're,
I agree with that.
something else. And, you need to this BLS is there just to give you the basics of how to deal with these things. If, it's a true cardiac emergency or true respiratory emergency, it tells you how to deal with these because those are what will likely lead to death the soonest. But other situations, it just advises to, monitor, call an ambulance.
Right.
So,
All right, I
who?
just wanted to chime in with that.
Oh, sure. Drew, do you want to talk us through how to do appropriate CPR?
Sure. So with appropriate CPR, it's good to know the age of your patients, because that will determine what you do. I mean, it'll affect your ratio. For adults, you'd want to do 30 chest compressions for every 2 breaths at a rate of
That's
100.
for one rescuer or two, right?
Yeah, that is a 1 rescuer to 2 rescuer, and then that's at a rate of 100 compressions to 120 per minute. If you're wondering a good way to try and stay on tempo, a good way that I've always been taught is remember the chorus to "Staying Alive." The
Play the clip from The Office.
Yeah.
Just
um,
the staying alive part, everybody. Come on.
and then if it's a pediatric patient, so a patient from, I can't remember the exact age range, but anywhere from like a kid to about 18 years old. For one rescuer, it is 30, 30 compressions per every 2 breaths. But if you have 2 rescuers, then it's every 50. You have 15 chest compressions for every 2 breaths, if I'm not mistaken.
Pretty sure that's right. And I think the reason being is usually younger people, um, their hearts are pretty healthy. So majority of the time they assume it's more of a respiratory problem. So doing the fewer amount of compressions allows us to give more respirations, like more breaths to the patient.
Exactly. And then your pediatrics, I believe it's the same whether it's a 1 rescuer or 2 rescuer. It just depends on your positioning, but it's going to be your ratio is about 15 chest compressions for every 1 to 2 breaths. Um, so and more towards the 2 breaths because again, it's not usually typically that it's a heart issue. It's more a ventilation or a breathing issue that the patient's going through because they are so young.
Right.
And then at the same time, you also want to make sure on adults you're going about 2 inches deep. So like we were talking about, usually the most case scenario, you will break the sternum, and you will feel that pop. And to be honest, it's a feeling I don't think you'll forget. I still
Yeah,
remember
no.
very vividly the first ribs that I cracked doing CPR. And then
I would say it doesn't happen as much in kids because their ribs are still,
Flexible.
yeah,
yeah, I was gonna say like cartilage in it, but it escaped me.
Cartilage.
Yeah, but yeah, they're pretty fragile. They yeah, they're more pliable. So I don't know if ribs breaking in kids is as common because they rebound really quick.
yeah. But you want to go again, and it's down to where you can feel the sternum, just right below the nipple line on everyone that you do this on. Um, but for kids and pediatrics, you kind of just want to go about a third of their chest depth, and that would be
I thought that was for everybody, but for like an average adult, a third of their chest diameter is 2 inches.
right.
Is that right or am I wrong?
That's what I've come to understand.
I know like pediatrics, you do a third or 2 inches. Neonate, it's a third or an inch and a half.
Yeah,
I've
an
always
inch and a
just
half.
remembered a third. I mean, nobody's got a measuring tape. I don't even know how you would measure if
Yeah, I
you're
know for sure
actually.
it's like 2 inches at least in adults.
Yeah.
But most of the time now, like AEDs and like they come with a compressing thing that calculates if you're giving effective compressions, and it'll talk to you while you're doing compressions. It'll be like, you need to compress deeper, you need to compress faster, you need to allow recoil, stuff like that.
Yeah, and
So
it's good
there,
to know that
there
from.
you go, Trevor. There's your phone idea right there.
Yeah.
They might already have it. I'm sorry.
But
They do have those things that you can put under your hand while you do chest compressions. Have you guys seen those monitors?
I have.
Yeah, that was pretty much what I
Yeah.
was trying to talk about. Was that, yeah, and it gives you real time feedback.
And it's also good to know that for it to be considered effective chest compression, yeah, you have to go deep enough, but at the same time, you have to allow the chest to expand like it should to allow that heart to adequately pump the blood that it needs to. Because if you're not allowing that heart to fully expand or the chest to fully expand, you're not allowing that blood to circulate through the body, and you're not effectively giving that victim chest compressions.
So yeah, like Drew was saying, you need to allow proper like chest recoil so the heart can refill. I think that's where most people make a mistake when doing chest compressions, is they don't fully come off. Like they don't fully like let the chest expand again. I feel like it's kind of that panic situation. Like you're like, oh, I need to hit 100 to 120 chest compressions, and just going as fast as you can. Like it's it's not very difficult to go too fast sometimes, because you're just like, I need to get the heart rate going again, and um, I feel like if you go too fast, you're not allowing effective recoil.
Exactly.
Yeah, and what I've always understood is that we would rather get appropriate recoil than, um, going the right speed. Of course, you don't want to go too slow, but you want the heart to truly fill with blood before you actually push it out.
Exactly, because with compressions, you're pretty much doing the work of the heart. Like it, for some reason, the heart has stopped, and that's why you don't have a pulse. So you're pretty much circulating that blood through your compressions. At least that's the idea behind it.
So that was, just a quick summation of BLS. Of course, you should go to a proper certified instructor to learn these things, but I hope we gave just a little bit of an insight so that you may be able to help save someone's life out there if you're out and about and you come across someone that's unconscious. Um, Now, unfortunately, due to time, we haven't been able to talk about everything we wanted to talk about this podcast episode. So we will continue discussing emergent situations and some of the life-saving techniques we have as respiratory therapists and as healthcare providers in part two. Catch you then. Well, this has been Don't Hate, Ventilate. So, see you later.